Very good morning. And at the outset, sincere thanks to the organizers, Dr. Deshmukh, Dr. Sheikh, and the organizing team for having me here. So Dr. Deshmukh has specifically asked me to keep my talk clinical and not to bore you with data and statistics, and I will follow her advice. So let me start with two clinical scenarios. So a young lady, 45, attained menopause at 43, BMI 23, no comorbidities, but she complains of severe hot flushes and mood swings. And you have another lady who is 63, BMI of 36, diabetic, hypertensive, menopause at the age of 54, heard about HRT, otherwise asymptomatic, and wants to take it just for general well-being. So before I tell my perspective as an oncologist for these two cases, let's go through some of the relevant questions. And important issues are, does HRT increase the risk of breast cancer? If yes, are there population who are higher risk than others? And does the type of HRT preparation and the duration of use affect the risk? Does HRT also increase the risk of other cancers? And lastly, I'll also touch upon the issue of HRT use in cancer survivors. So first, to answer the first two questions, I will largely use Women Cancer Health Initiative trials data. So I'm sure you all know that Women's Health Initiative, it's the largest randomized control trial addressing the issue of HRT. So essentially, more than 27,000 postmenopausal women between age of 50 to 79, they were recruited between 1993 to 1998 at 40 centers in US. And based on whether they had uteri or not, there were two trials within this study. So the first trial was in women who had intact uterus, and here the test arm used conjugated equine estrogen dose of 0.625 plus MPA in a dose of 2.5 milligram every day, or placebo. That was the randomization, and women without uteri were randomized to a single dose of CEE or placebo. The primary efficacy and safety endpoints were CHD and invasive breast cancers, and the trials were terminated at 5.6 and 7.2 years after the initiation. So first, let's look at the combined arm or study of this trial. So women who received CECE plus MPA, and as I mentioned, the trial was actually prematurely stopped at 5.6 years. Initial plan was to continue until 10 years, and the stoppage was because of safety concerns. And what were the concerns? Women who received combination hormone therapy, there were significantly higher incidence of breast cancer with a p-value or hazard ratio of 1.26. So essentially, there was, if we take combined estrogen progesterone pill, there was 8 more invasive cancer in 1,000 person year. So that was the additional risk. The other study, which was estrogen only arm, was also stopped at 7.2 years. However, this study did not show any increase in the incidence of invasive breast cancer. In fact, there was a reduction in the incidence of invasive breast cancer. The combination arm showed a reduction in the incidence of colorectal cancer. However, that same benefit in terms of colorectal cancers was not seen in women who received estrogen-only therapy. And more recently, we have long-term data on breast cancer survival and mortality from WHI study published in 2020. And what it showed, that combination hormone therapy was associated with statistically significant higher breast cancer incidence with a hazard ratio of 1.28, and this is long-term data. So increase in the incidence of breast cancer in combination continues. However, there was no difference in breast cancer mortality in these women, while estrogen alone compared to placebo was associated with statistically significant reduction both in the incidence of breast cancer as well as breast cancer related mortality. So we know that WHI actually is one of the most influential and popular study which has really changed clinical practice over times, and it was also hugely criticized and looked at very, very critically. So some of the limitations of WHI study may be that women in this trial, they were largely asymptomatic, and they were much older than the usual age of prescribing HRT. So the median age was 63 years in this study. So there is a thought that these results, especially in terms of risks of HRT, may not be applicable to younger women. The other point is that this study tested only one preparations of estrogen and progestogen and only one doses. So there is a possibility that with recent estrogen as well as progestogens, safety and efficacy of other formulations, regimes, and delivery methods may have better toxicity or side effect profiles. Also, lower dose of hormonal therapy and transdermal route are likely to have less risk, especially in younger women. But to substantiate all these, we do not have any data. There is one French group study which showed that micronized progestogens have fewer adverse effect on breast compared to MPA. Recently, this collaborative group, they looked at a number of studies with a huge population. It's a systematic meta-analysis, which included 58 studies, or 24 of them were prospective, all published between 1992 to 2018. So huge number of women were included in this analysis. And the results of this again showed that every HRT type except vaginal estrogen was associated with excess breast cancer risk. However, if you see here, the risk is highest with combination HRT and the least with estrogen only HRT. The continuous had higher risk compared to sequential preparation, and risk did not differ whether you used oral or transdermal estrogen. The risk continued at least 10 years after the stoppage of HRT. The least risk was when we use HRT for a year or less. So that's very robust evidence on HRT and breast cancer. And another very interesting finding from this study is that obese women, obesity per se is a risk factor for breast cancer, regardless of the use of HRT. And the similar inference have been actually from WHI, a secondary analysis of WHI, which was published in 2015. And it showed that women who have BMI 35 or more, they have significantly increased risk of breast cancer compared to normal women with normal BMI. And also, obesity was associated with higher number of ER/PR positive, more advanced disease at presentation, and also higher breast cancer mortality. So obesity per se is a risk factor both for higher incidence of breast cancer and as well as associated mortality. And in this study, there was no relationship between menopausal hormone use in obese women. So let me just put things together. Let's talk about oncological safety of HRT, largely these inferences from WHI plus other studies. So breast cancer, estrogen alone, HRT, there is either no or little risk of breast cancers. However, combined estrogen and progestogen is associated with increased risk of breast cancer, and that is duration dependent. Micronized progestogen may be a little better, but we do not have level 1 evidence. However, vaginal estrogen cream is the only preparation which has not shown to increase the risk of breast cancer. What about endometrial cancer? We all know if you give only estrogen, there is increased risk of endometrial cancer. In fact, a year of unopposed estrogen can increase the risk of endometrial cancer to the tune of 30%. Sequential HRT more than 5 years has shown to increase the risk of endometrial cancer, and that is inversely proportional to the number of days we supplement progestogen. Continuous combined HRT in WHI study showed reduction in endometrial cancer risk during the follow-up stage. Ovarian cancer, so WHI actually showed no increased risk of ovarian cancer both in combined and ERT alone arm. However, there are epidemiological studies suggesting that the risk of ovarian cancer, especially serous and endometrioid type, may be increased both with combined and ERT. So one has to be little careful, especially in women with family history of ovarian cancer. Cervical cancer, there is no impact, unlike oral contraceptive pills. And when we talk about colorectal cancer, WHI showed that in combined arm, there was reduction in colorectal cancer, which once you stop, it becomes to the same as in general population. However, estrogen alone arm had no effect on reduction in colorectal cancer risk. Just a word about this special population, women who experience premature menopause. So generally it is believed that HRT is safe and can be prescribed and should be continued until the age of natural menopause, unless there is a contraindication to HRT like hormone-dependent tumor or breast cancer, where you should not give. Women who have had undergone risk-reducing salpingo-oophorectomy, like those who are BRCA1 or 2 mutant, as a part of reduction in ovarian cancer risk, they experience premature menopause, and HRT can be safely used in these women. It has not shown to increase the risk of breast cancer. I think I have 2 minutes, 2.5. So quickly about HRT in cancer survivors, and this is extremely important with increasing incidence of young women getting cancers. This has become an important quality of life related issue for these women. So when we talk about HRT in breast cancer, Scandinavian trial habits was started. However, it was closed prematurely because there was increased number of new breast cancer cases in women who were breast cancer survivors and given HRT. So after this trial, actually there is no further trial, and now what is generally believed that breast cancer is an absolute contraindication for systemic HRT, regardless of hormone receptor status of the breast tissue. So if women have symptoms, non-hormonal options should be used for their management. Women who are not responding to non-hormonal treatment, vaginal estrogen, that's the only preparation which has not shown to increase the risk of breast cancer, and that can be considered, especially women who have genitourinary syndrome of menopause. And when women, if they are using vaginal estrogen cream and if they are taking anti-estrogenic therapy in the form of aromatase inhibitors, they should be switched to tamoxifen. What about phytoestrogen? Can we use phytoestrogen? The answer is a big no, because we really don't know their safety in hormone receptor positive tumors. So just to tell about other cancers in HRT in cancer survivors. So breast cancer, as I said, HRT is absolutely contraindicated. Endometrial cancer, so studies have shown that in early stage, especially after maybe 12 months when we use HRT, it has not shown to increase the risk of recurrence. So it can be used. However, same may not be true for early advanced stage disease. Ovarian cancer, there are no adverse effect of HRT in epithelial ovarian cancer. The exception will be hormone receptor positive ovarian tumors like granulosa cell tumor or low-grade serous carcinomas, so which are ER/PR positive, and their HRT is contraindicated. Cervical cancer as well as vulvovaginal cancers, there is no issue in giving HRT, both systemic and oral, whichever form it can be used if clinically indicated. So to summarize, combination HRT has been shown to be associated with increased risk of breast cancer, which appears to be duration dependent and also may vary with type of progestogens. So as I said, we don't have level 1 evidence, but there are some epidemiological studies suggesting that micronized progestogen may be better than MPA. Estrogen alone HRT is associated with little or no change in breast cancer risk. Vaginal estrogen is associated, is not been associated with, so that's the only preparation can be used. The WHI showed no increase in the risk of ovarian cancer, but epidemiological studies do suggest there may be increased risk of certain types of ovarian cancer. So the bottom line is, as an oncologist, my recommendation would be to use HRT for symptom management, but not for chronic disease prevention. And that's not supported by WHI, the largest randomized trial. Are we wondering whether same are true for India? So unfortunately, we don't have too much data for our country, but what we know that breast cancer is the leading cancer in our country and the number of cases are increasing. So this is, breast cancer has become the #1 cancer in Indian women. And biologically, there is a possibility that Asian, we are genetically different, but again, there is no data to suggest that HRT will behave differently in Indian women compared to the West. Just last, let's come back to where I started from. So what about the young lady who has acute symptoms? As an oncologist, I would say, yes, we can give her HRT for the shortest possible duration to elevate her symptoms. However, a lady, older one with diabetes, hypertension, and obesity, who just wants to take as, you know, as just for well-being, my recommendation as an oncologist would be no. So the bottom line is we are in the era of personalized medicine and we have to choose wisely. And also a very important point is to have discussion with the patient and understand their views. So with this, I'll stop. Thank you very much.